I am Dr. T. Sudha, Department of Pharmaceutical Chemistry and Analysis, Associate Professor, Wales Institute of Science and Technology and Advanced Studies, VISTAS, Pallavaram. Today's my topic is Scrub Typhus. It contains etiology, vector biology, pathogenesis, and diagnostic workup and evidence-based management. இது நவர மாட்டேங்குது.
இதுக்கு மேல கிளிக் பண்ணணும். ஸ்லைடுக்கு
அந்த செலக்ட் ஆகக்கூடாது ஸ்லைடு.
இப்போ இங்க வெளியில செலக்ட் பண்ணல, ஸ்லைடு செலக்ட் ஆகக்கூடாது.
ஓ,
வெளியில இங்க கிளிக் பண்ணிட்டு ஃபர்ஸ்ட்ல இருந்து பண்ணுங்க.
Good morning to one and all. I am Dr. T. Sudha, Associate Professor, Department of Pharmaceutical Chemistry and Analysis, School of Pharmaceutical Sciences, Wales Institute of Science and Technology and Advanced Studies, VISTAS. Today's my presentation is Scrub Typhus. It contains etiology, vector biology, pathogenesis, clinical manifestation, diagnostic workup, and evidence-based management. What is the meaning of Scrub Typhus? The disease definition and overview. It is an acute zoonotic rickettsidal illness caused by Orientia sussmani, presenting an acute undifferentiated fever and characteristically marked by an inoculation azure. What is the epidemiology and Sussmani triangle? That is a geographical endemicity. It prevents across Sussmani triangle covering over 13 million kilometers square from northern Japan and eastern Russia, south to north Russia, and west to Pakistan and Afghanistan. Over 1 million people live at risk, with approximately 1 million clinical cases occurring annually, making it a leading cause of acute non-malarial illness in Southeast Asia. What is the transmission and seasonality? Transmission occurs primarily in mite island, focal microhabitat with scrub vegetation, overgrowth, cleanliness, and riverbanks harboring mite colonies. The year-round transmission occurs in tropical zones, whereas temperate zones exhibit distinct seasonal peaks during many season or late autumn when larval mites hatch. Then what is the etiology and microbiology? It obligate intracellular pathogen. It is caused by Orientia sussmanis. It is a gram-negative obligate intracellular bacterium within the family Rickettsia. It is a unique cell wall structure. Unlike standard gram-negative bacteria, Orientia sussmani lacks. It is a peptidoglycan and lipopolysaccharide, that is LPS, in its cell wall, confirming intrinsically resistant to beta-lactam antibiotics. Antigenic heterogeneity. It expresses a measure of 56 kDa strain-specific surface protein antigen with substantial antigenic variability, and it keeps in variability. Next, vector biology and transmission cycle. It is that is 4 types of transmission cycles are there. One is primary vector. It is transmitted by larval transmit mites, that is a predominantly species of Lactobrium, for example Delnus and L. oculus. Obligate parasitic stage, only the larval stage. It feeds on maintain lymph and tissue fluid, and adult mites are free living soil predates. Third one, reservoir maintenance, maintained via Transoviral and transdial transmission within mite population occurs generation. What is the accidental hosts? It means that is human becomes accidentally infected when entering the infected spur vegetation and stepping in active mite hotspot. What is the pathogenesis and the disease mechanism? It is a 4 types. One is inoculation and local replication. Second one, dissemination and vasculitis. Third one, endothelial dysfunction. The clinical presentation and initial onset, it is four category. Incubation period, that is a range of 6 to 21 days, typically 10 to 21 days post chigger bite, and abrupt febrile onset, high grade continuous or remitted fever, that is 104 degree Fahrenheit or 40 degrees Celsius, accompanied by shaking, chills and rigors. Third one, constitutional symptoms, severe incapacitating retroorbital headache, generalized intense malaria, anorexia and malaise. Then fourth one, ocular and upper respiratory findings, conjunctive injection, then phytophobia, dry cough, and mild tachypnea in the early stage. This picture shows bite, insect bite, then morphology and evaluation. It begins a painless erythromites papullae at the bite site, rapidly ulcerates and form a characteristic black necrotic crust surrounded by an erythromatous halo. It is 3 to 10 mm diameter. Diagnostic hallmark present in 30% to 80% confirmed cases. Depending on strain virulence and host immunity, it is a virtually pathogenic of scrub typhus in endemic regions. Anatomical distribution most commonly discovered in warm, most flexural body to fold regions. For example, axilla, grain, and inguinal crisis, amblicans and belt line, inflammatory folds, and neck. Physical examination findings, 35% centrifugal mucopolar rash, systemic clinical signs, that is a marcopolar exanthem, develops between days 7 and 4 of illness, starting on the trunk and spreading centrifugally of limbs, usually non-frenetic, and fades in 3 to 5 days. Generalized lymphadenopathy, predominant lymph nodes enlargement, particularly drilling the anatomical region of the acer. That is reticuloidal anomally. It is observed in approximately 30 to 50% pediatric and adult cases. Clinical presentation. Next, systemic complication. Systemic complication and MODS. It is 3 types. One is pulmonary and renal. Non-cardiogenic pulmonary edema, severe interstitial pneumonitis, and acute respiratory distress syndrome, that is ARDS. Acute kidney injury, AKI, due to acute tubular necrosis. Next, central nervous system. It causes neck stiffness, confusion, and central nervous paralysis. Then cardiovascular and blood, myocarditis, arrhythmias, collapse, disseminated intracellular coagulation, DIC, and severe thrombocytopenia. Next, laboratory parameters and frequency, that it is determined by the hepatitis terminitis. That is, go for a test for AST or ALT, 85%. Thrombocytopenia, that is less than 1,50,000 mul, that is 75%. Hypoalbuminemia less than 3.5 gram per dl, that is 60%. Leukocytosis or leukopenia, that is 50%. This is laboratory parameters and frequency. Diagnostic workup and confirmation. Gold standard serology, indirect immunofluorescence assay, that is IFA showing that is greater than or equal to 4-fold rise in paired IMG or IgG antibody trials. Next one, molecular diagnostic, go for a PCR studies. Nestus PCR targeting 56 kDa TSA gene on whole blood or A-shell swab specimens. Highest early yield. Well flexi test, OKRK, historical agglutination test, low sensitivity and specifically no longer recommended as solo diagnostic. Differential diagnosis matrix, that is disease entry, etiology, distinguishing feature, diagnostic test. Diagnostic test, for example, IgM, ELISA or Acer PCR, NSI antigen or AGM ELISA, peripheral smear RDT test, then IgM ELISA or MAT test, blood culture. These are all the tests useful for. First one, Scrub Typhus. That is, you have to find out what type of bacteria it is present. That is called Orangia Tusmania. That type of that is bacteria, if it is identified by the diagnostic test, is IgM, ELISA or Acer PCR test. Then dengue fever, that is a dengue virus, you go for a NST antigen IgM ELISA test. Malaria fever, go for a, that is Plasmodium spp bacteria analyzed by RDT test. Leptospirosis, that is Leptospiria infrograns, that is test analysis by MAT test or IgM ELISA. Typhoid fever, Salmonella typhi analyzed by blood culture or viral test. Pharmacological management, you have to go for a first line antimicrobial therapy. For example, doxycycline 100 mg, PO or IV twice daily for 7 days. Rapid responses, it is usually occurs within 24 to 48 hours of initiation. Lack of responses suggested an alternative diagnosis or resistant strain. Next one, alternative and special population. In case of something, doxycycline or penicillin, that is allergy, if it is having, means you go for a azithromycin 500 mg PO daily for 3 to 5 days. Preferred first line drug in pregnant woman and pediatric population. Sometimes a doxycycline resistance, you go for a azithromycin or rifampicin 600 to 900 mg per day. It is indicated in areas with known doxycycline resistant strains. Prevention and prognosis. Prognosis is excellent with prompt antibiotic therapy. It is untreated cases carry up to 30% mortality. Thank you for watching this video for scrub fever. Thank you.